Hi, I'm Carla Pecoraro.
I'm Anne Woolfield.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things ONG. Today, we're going to continue our discussion of perinatal infections and talk about the management of HIV in pregnancy. Let's start off with some background information of the pathophysiology of HIV. And what is HIV?
Well, HIV is an RNA virus. Once infected, it attaches itself to CD4 T cells, replicates within the cell, and then kills the cell so it is released and spreads. This is why in advanced disease there are low CD4 counts. CD4 T cells are an essential part of the immune system which coordinates other cells to fight infection. You can see how, then, those with advanced disease are more susceptible to certain infections. Advanced HIV is when the immune system is significantly damaged, and it's called AIDS, or acquired immune deficiency syndrome. AIDS is defined as a CD4 count of less than 200, or an infection with an opportunistic infection. There's also a difference between HIV-1 and HIV-2. To be honest, before looking into this episode, I did not realise there was two different types of HIV. Generally speaking, HIV-1 is more prevalent worldwide, it's more virulent, and it's more likely to progress to AIDS. HIV-2, on the other hand, is more prevalent in the West, less likely to progress to AIDS, and has a slower, much more indolent process with a slower decline in CD4 counts and lower plasma viral loads.
Interesting. So how would somebody with a HIV infection present?
The symptoms of an acute HIV infection are similar to other viral prodromes or a flu-like illness and include fever, fatigue, rash, headache, lymphadenopathy, pharyngitis, myalgias, nausea, and diarrhea. These symptoms are typically seen with HIV-1 infection because of the rapid viral load replication. HIV-2, on the other hand, tends to remain asymptomatic for many years. The main complications of HIV relate to AIDS and opportunistic infections. For those of you who don't know what opportunistic infection is, it's basically an infection with a pathogen that doesn't typically cause disease in people with healthy immune systems. When a person has an infection like HIV or AIDS, their immune system is weakened, allowing these otherwise innocuous pathogens to take advantage of the fact that the immune system is unable to defend the body effectively. Basically, these infections thrive at the opportunity to kick you while you're down. Patients with AIDS who contract opportunistic infections often get the most severe forms because their body isn't able to fight the infection. Some examples of opportunistic infections include cytomegalovirus, candidiasis, toxoplasmosis, HSV, tuberculosis, and pneumocystis jirovecii.
How do we discover HIV?
Well, the first case of HIV was reported in 1981. Doctors noticed outbreaks of rare infections in groups of gay men and realised that these were opportunistic infections, indicating that their immune systems weren't working. This then coined the terminology AIDS, or acquired immunodeficiency syndrome. In 1983, scientists discovered a virus in the lymph nodes of patients with AIDS. The virus was initially called lymphadenopathy-associated virus, later known as HIV, human immunodeficiency virus. There was actually a huge drama around the discovery of the HIV virus. Two competing research groups in France and the US were vying to be the first team who discovered HIV. Both teams published their findings around the same time, but there was significant overlap and similarity in their work, leading to fierce dispute over who had actually discovered the virus first. The French research team actually accused the US team of scientific misconduct, claiming that the US team had taken the French virus samples and used them to make the claim that they discovered the virus first. In the end, the French team were awarded a Nobel Prize for their discovery of HIV, but the US team was recognized for their role in proving that HIV was linked to AIDS. So much drama.
So let's talk a little bit more about the association of HIV with homosexual men.
Because HIV was initially identified because of clusters of rare infections and cancers in gay men, HIV was initially dubbed the gay plague. In the early years of the epidemic, the virus was largely perceived as a gay disease, leading to the marginalisation of gay communities. This perception was reinforced by sensationalist media coverage, which often blamed promiscuity and homosexual behaviour for the spread of the virus. Many conservative groups actually preached the idea that HIV was God's punishment for being gay. There was such huge stigma and discrimination associated with the disease that for years governments weren't putting any money into funding HIV research and treatment. It was actually an activist group of homosexual men who raised money to start their own research on HIV, which triggered development in HIV treatment. It wasn't until people realized that HIV was also affecting straight white men that the government started to take HIV seriously and actually put money into the development of treatment. Nowadays, we know that HIV is a disease that can affect everyone, especially those who are the recipients of penetrative intercourse. In males, 83% of HIV is attributed to male-to-male sexual contact, and in females, 83% is attributed to heterosexual contact. If you look into the history of medicine, there are so many stories of stigma, discrimination, and inequity, and the HIV epidemic is a very, very clear example of this. It was such a horrific time for our LGBTQIA+ friends.
Yeah, such a horrific and awful story. Not to plug another podcast, but there is another podcast called This Podcast Will Kill You, which has an episode on HIV, and they do a really good job of going into all of the dramas around this and what people who with HIV actually experienced during that time. So I really recommend you listen to it. It's really eye-opening. So how does a person get infected with HIV?
So generally speaking, HIV is transmitted through exposure to infected bodily fluids. So this can be sexually transmitted, parenteral, as in a needle stick injury, and through mother-to-child transmission. MTCT, or mother-to-child transmission, or vertical transmission, can occur in utero, during delivery, or through breastfeeding. The transmission rate is increased if they're co-infected with another STI, such as hepatitis C.
Oh, gee. How likely is it that I'll get HIV if I get a needle stick by someone with HIV?
Don't worry, Carla, it's incredibly rare. The rate of transmission is 0.3% through percutaneous exposure to infected blood. Now let's move on to the epidemiology of HIV.
So the overall prevalence of HIV in the Australian population remains low at about 1 in 1,000. The peak number of new cases occurred in 1987, followed by a rapid decline. There was a lot of energy put into prevention practices, which included things like HIV testing, safe sex practices, clean needle and syringe programs, and stringent treatment of blood products. The burden of HIV still tends to be among the disadvantaged in low and middle income countries, with about 75% of infected women living in sub-Saharan Africa, Central America, and the Caribbean. According to the Global Burden of Disease report published last year, however, the gap between high and low income countries for the burden of HIV has narrowed over the last 20 years. So we know HIV is important, but why do we care about it in pregnancy?
It's important to know about it because many women are first diagnosed with HIV in pregnancy with the possibility of vertical transmission. The CDC recommended HIV screening in pregnancy from 1991 since there was increasing evidence of transmission to babies. In 1994, studies showed that zidovudine significantly reduced the rates of mother-to-child transmission, giving further support to guidelines to recommend HIV screening in pregnancy.
Now, if you've been listening for a while, you know we like to chat through a case to get across all this information. So let's meet Sarah. Sarah's a 29-year-old G1P0 who's moved from sub-Saharan Africa. She's currently 12 weeks pregnant and was referred from her GP with a positive HIV serology. What does this mean?
So when you order HIV serology, the lab runs something called an enzyme immunoassay test. This basically looks for the presence of antibodies to HIV. If a person tests positive for HIV antibodies, the diagnosis must be confirmed through a second test called the Western blot. If the Western blot is positive, then this is a confirmed HIV infection. If the Western blot is negative, then you repeat the HIV testing in 4 weeks if there's been a recent exposure or a re-exposure. Remember, no test is perfect, and so there is always the possibility of a false positive result, although this is pretty rare. If the Western blot is indeterminate, then further testing is required, and you should really discuss this with a physician who specialises in HIV.
So Sarah tested positive to HIV on her routine antenatal serology. We had a discussion last time about screening for syphilis during pregnancy, but when do we screen for HIV?
HIV is routinely tested in the first trimester with the antenatal screening bloods. ACOG recommends retesting at 36 weeks for those at high risk. High-risk patients include those with multiple sexual partners, a diagnosis of another STI, a suspected or known HIV-infected partner, IV drug use, and those who are sex workers. So what's the next step for Sarah?
Well, first we need to chat to Sarah about HIV and the implications for her and her pregnancy. we should discuss with her that it is a notifiable disease and that it leads to immunosuppression. We need to discuss that it is highly contagious to her partner and the risk of transmission to her baby. Sarah should be encouraged to perform contact tracing and to engage in safe sex practices. We need to liaise with Sarah to determine when she most likely became infected and do contact tracing for that time frame. And of course, let her know that there is treatment. Next, we involve our multidisciplinary team, including an infectious diseases specialist or a physician that specialises in HIV, an obstetrician, anaesthetist, and a paediatrician.
Now, for Sarah, we need to perform some additional tests. These include a HIV RNA viral load, HIV resistance testing, a CD4 count, full blood count, UECs, LFTs, and a screen for other sexually transmitted infections, including syphilis, Hep C, Hep B, chlamydia, and gonorrhea. You should also consider testing for HIV-related infections, including a chest X-ray and bloods for TB testing, CMV, varicella, and toxoplasmosis. It's also really important that we test Sarah's partner for HIV, as well as any other children if she has any. These investigations are important because they help assess the progression of HIV, options for treatment, co-infection with another STI, and the possibility of opportunistic infections.
Then we need to talk about the impact of pregnancy on HIV. In asymptomatic women with a low viral load on antiretroviral therapy, pregnancy probably doesn't have a huge impact on the disease progression. In women with advanced HIV, though, there is a risk of deterioration during the pregnancy. But this is probably not secondary to the pregnancy. It's just that these women are generally at high risk of deterioration. Opportunistic infections may not be recognised or treated as aggressively. This may be because some of the symptoms are masked by pregnancy or because of concerns for the fetus. There's no evidence that pregnancy increases the risk of AIDS. Because of these risks, we need to stress the importance of vaccinations, including hepatitis A and B, pertussis, influenza, and pneumococcal. Pneumococcal vaccination is not generally recommended in pregnancy, but you would consider its use prior to pregnancy, immediately postpartum, or during pregnancy in consultation with an ID specialist because of the immunosuppression related to HIV. Now, what about the impact of HIV on the pregnancy?
Well, as with many perinatal infections, there is an increased risk of miscarriage, preterm birth, fetal growth restriction, and low birth weight. There's no increased risk of congenital anomalies with HIV or its treatment. We haven't really discussed congenital anomalies in great deal in previous episodes, but the background rate is about 2 to 3%. And so with HIV, there's no increased risk above this background rate. There is a high rate of false positive with the combined first trimester screen because HIV increases the beta-HCG and also decreases the AFP and estradiol for those choosing second trimester screening. And of course, the risk of vertical transmission.
In those without treatment, the risk of vertical transmission of HIV is as high as 41%. But fortunately, with adequate prophylaxis and treatment in pregnancy, we can reduce the rate of vertical transmission to less than 1%. The key features of preventing mother-to-child transmission include treatment with antiretroviral therapy, avoiding breastfeeding, and appropriate mode of delivery.
Yes, treatment. Tell me more.
So one of the best discoveries in medical history is antiretroviral therapy. The preferred treatment is combined antiretroviral therapy, or CART, and to start this by 20 weeks gestation. The reason for this treatment is both for the mother and the baby. For the mother, this reduces the viral load and essentially prevents progression to AIDS. For the fetus, it helps to prevent mother-to-child transmission. There have been very few cases of vertical transmission within the last 5 years. Only 1.8% of all perinatal exposures. According to the WHO, globally, an estimated 1.3 million women and girls with HIV become pregnant every year. And like Mel said, in those without treatment, the rates of vertical transmission are incredibly high of up to 41%. In appropriately managed patients, however, the rate of MTCT is less than 1%. There are a few risks associated with combined antiretroviral therapy, and these include an increased risk of preterm birth and preeclampsia. There's also an increased risk of gestational diabetes on those on protease inhibitors.
So I was actually looking at some stats the other day, and they've got some data showing exactly how many babies per year in Australia are born with HIV. And our number's been consistently sitting somewhere between 2 and 4 babies per year nationwide, which I thought was pretty interesting. Still too high. Hopefully we can get it lower. But good to know. Now, for all of you who has previously studied HIV and antiretroviral therapy, there is no difference between highly active antiretroviral therapy or HAART, combined antiretroviral therapy, which is CART, or just antiretroviral therapy. They're all the same thing. The standard of treatment is combined therapy, and thus the newer terms are just CART or ART. Now, let's talk about ART in pregnancy. First, if a patient conceives on antiretroviral therapy, then the recommendation is to continue her regimen. If a patient is ART naive and needs the treatment for her own health, for example, if she has a low CD4 count, then she should start the ART as soon as possible. In the case of a patient who's not on ART, who doesn't need to start the therapy immediately, then she should at least start this in the second trimester prior to 24 weeks. And in the case of a patient presenting late who isn't on antiviral therapy, then it should be commenced immediately. There are some antiretroviral medications which readily cross the placenta and are used in certain situations to load the baby before delivery. These include nevirapine, raltegravir, or double-dose tenofovir. The next step to reduce mother-to-child transmission is the use of intrapartum zidovudine.
So let's get back to Sarah. In summary, our management plan so far has included informing Sarah of her diagnosis and that it is a notifiable disease, explaining that HIV is highly contagious to partners, has a risk of vertical transmission of up to 41%, and the importance of contact tracing and safe sex practices. Next, we've engaged our MDT with a HIV specialist and ID specialist. Then we arranged for further investigations, including HIV RNA viral load, HIV resistance testing, CD4 count, FBC, UEC, and LFTs, testing for other STIs such as hepatitis B, C, syphilis, chlamydia, and gonorrhea, and testing for HIV-related infections like CMV, toxoplasmosis, and varicella zoster. We've started Sarah on ART by 24 weeks, explaining the small increased risk of preterm birth, and we've encouraged her to be up to date with all vaccinations. So let's discuss the ongoing management for Sarah. Aside from an infectious diseases specialist, Sarah should be managed as a part of a high-risk obstetrics clinic and involve other team members, including a pediatrician or neonatologist, GP, and midwife. Consider offering psychological support given how stressful a diagnosis of HIV is. We should ensure that Sarah is on high-dose folic acid of 5 mg daily when she's on CART and arrange serial growth ultrasounds. She should have regular monitoring of her bloods. This includes monthly viral load, CD4 count, and LFTs. And remember, she's at a higher risk of GDM if she's on a protease inhibitor and should have an early OGTT. We mentioned earlier testing for HIV-related infections, so if Sarah had a CD4 count of less than 200, which is consistent with AIDS, and a history of pneumocystis pneumonia, she should be started on code tromoxazole. This is to prevent infection and protect against toxoplasmosis reactivation.
Now, we mentioned before about the risks of false positive screens with first trimester screening, but tell me a little bit more about that, Anne.
Yeah, so interestingly, there's a higher rate of false positives for the combined first trimester screen in those with HIV because of a higher beta-HCG and lower AFP.
So we should be recommending the NIPT for these patients. And so what do we do if they have a high-risk NIPT or high-risk combined first trimester screen? What's the deal with chorionic villus sampling and amniocentesis?
Well, ideally, you should wait until the viral load is less than 50 HIV RNA copies per mil. And those with an unknown serology during the pregnancy, you should complete the serology prior to CVS or amniocentesis. In those with a high viral load and a high-risk combined first trimester screen, and they couldn't afford a NIPT, or they had a high-risk NIPT, it would be a difficult decision about whether to go ahead with invasive testing and when this best time would be.
Yeah, I've read that you need to wait for that viral load to be under 50, but I don't know how long that takes in practice. What about another possible tricky situation, an external cephalic version or ECV if the baby's breech? Is that a contraindication?
So HIV is generally not a contraindication to ECV, especially if the viral load is less than 50. There's minimal evidence as to whether it's safe for those with a viral load higher than this. But as we'll go into shortly, at least in Australia, we recommend a caesarean if the viral load is above 50 anyway.
So let's get to the nitty-gritty of delivery. For our listeners' reference, in this episode, when we're discussing caesarean section, the indication is purely for the prevention of vertical transmission. The evidence regarding cesarean for the prevention of vertical transmission is when this occurs prior to labour. Because of this, the recommendation is for cesarean section between 38 to 39 weeks. What do the guidelines say about who should have a cesarean, you ask? Well, let me tell you. ACID, or ACID, which stands for the Australasian Society for Infectious Diseases, has an amazing guideline on all perinatal infections. All you need to do is Google ACID perinatal infections. Thank me later. The recommendations regarding the mode of delivery is determined by a viral load at 36 weeks. According to ACID, if the viral load is less than 50 and the patient is on ART, then the patient can plan for a vaginal birth. If the viral load is over 400, then a cesarean is recommended at 38 to 39 weeks. With a viral load between 50 to 399, ACID still recommends a cesarean section. The British HIV Association suggests that in those with a viral load between 50 and 399 RNA copies per mil, a pre-labour cesarean should be considered. But in these cases, you should factor in the actual viral load, trajectory of the viral load, treatment, adherence, obstetric factors, and maternal preference. Interestingly, guidelines from the USA suggest that a pre-labour cesarean should only be recommended in those with a viral load more than 1,000 RNA copies per mil.
Yeah, that is so interesting. So I remember when I was studying, it's less than 50 is definitely a vaginal birth, over 400, definitely a Caesar. And then between 50 and 400, it's like you could really go either way. It's not a whole lot of evidence for either, but they seem to have changed their guideline into more favouring cesarean sections, which is interesting.
Yeah, the Australian one's much more conservative versus the US, which is up to 1,000. You'll be right.
Yeah, you'll be fine.
Thank you, Carla. Now let's go through a few scenarios. So say Sarah is planning a vaginal birth. She's got a viral load less than 50. She's on ART. Do you need any specific labour precautions?
No. So in this situation, you can treat them as normal labour. Ideally, you should avoid fetal blood sampling and a fetal scalp lactate. But if you really need to do it, then it's technically okay if the viral load is under 50. Not sure how many people would feel comfortable actually doing that though.
And what if her viral load is less than 50, but she still wants a cesarean? When do you do this?
Usually just as per routine obstetric indication. So ideally after 39 weeks.
And what if Sarah comes in with term pre-labour rupture of membranes?
The aim is delivery within 24 hours. If the viral load is 400 or more, then immediate cesarean is recommended.
And what if Sarah ruptured her membranes at 34 weeks?
The management of preterm pre-labour rupture of membranes from 34 weeks and over should be the same as for term rupture of membranes.
Okay, but what if she ruptured her membranes less than 34 weeks?
In these cases, a multidisciplinary team approach should be employed to determine the timing and mode of delivery. The HIV viral load should be optimised.
And can Sarah have a VBAC with HIV?
Yep, as long as she's suitable for a vaginal birth. So if her viral load is less than 50, she can absolutely go for a VBAC.
And what about a water birth?
So the ACID guidelines don't specifically address this, but the British HIV Association guidelines suggest that if the viral load is less than 50 and she's going for a vaginal birth, then yes, you can absolutely support a water birth.
Okay, now when do we use this intrapartum zidovudine?
So the goal of using intrapartum zidovudine is to reduce the risk of vertical transmission. The indications for zidovudine include women with an unknown viral load or a diagnosis of HIV that's only made at the time of labour, women with a viral load over 1,000, or you can still consider it if the patient has a viral load over 50, women who are not on ART or who you suspect were not quite adherent with it. And for women having an elective cesarean section, you ideally want to start the zidovudine at least 3 hours before you go ahead with the Caesar.
All right, let's summarise the intrapartum recommendations. In those with HIV, on CART and a viral load of less than 50, a vaginal birth can be offered with routine intrapartum cares. In those with a viral load over 400, a pre-labour cesarean section at 38 to 39 weeks should be recommended. You should consider a cesarean section in those with a viral load between 50 and 399. In those with term pre-labour rupture of membranes, delivery is recommended within 24 hours, unless their viral load is 400 or more, and in this case, an immediate cesarean is recommended. In those with preterm pre-labour rupture of membranes at 34 weeks and over, the recommendations are the same as for term prom. In those with PPROM less than 34 weeks, the decision regarding timing and the mode of delivery should be individualised within an MDT. In these cases, ensure that the patient is on cart to optimise the viral load.
And the indications for IV zidovudine include women with an unknown viral load or a diagnosis of HIV in labour, women with a viral load greater than 1,000, but you can consider it in those with a viral load over 50, women not on ART or whom you suspect were not adherent. Now, what do we do in someone who presents late for antenatal care and is not on ART?
For those women who are in labour and term, ACID recommends a caesarean section unless there is an obstetric indication not to and giving IV intrapartum zidovudine. They also recommend a stat dose of nevirapine, immediate commencement of combined antiretroviral therapy, and adding either raltegravir or dolutegravir to the regimen. In those who are preterm and in labour, these recommendations are the same. In those who are not in labour and present more than 28 weeks, they should start on CART ASAP and include either dolutegravir or raltegravir in the regimen. I don't know why these are so difficult to pronounce. This is why you need a HIV specialist. In those with an unknown viral load or it's over 100,000, the recommendations are as we've already discussed. Commence CART ASAP, include the 2 difficult to pronounce medications, use intrapartum IV zidovudine, and plan a caesarean.
Great. Now we've covered intrapartum care. Let's move on to postpartum care. The main aspects of postpartum care include formula feeding, post-exposure prophylaxis for the neonate with antiretroviral therapy, and testing the neonate. Formula feeding is recommended for the prevention of vertical transmission. We should offer breast milk suppression therapy, such as with the use of 1 milligram of cabergoline. There are some contexts where this may not be the best option, such as low visor settings. In the situation where a woman really wishes to breastfeed, we should work with women for a transmission risk reduction approach. ACID and the British HIV Association have a few suggestions for safe breastfeeding. It involves adherence to strict CART, a suppressed viral load, exclusive breastfeeding for the first 6 months, and avoiding mixed feeding or solids prior to 6 months of age. Mixed feeding increases the rate of vertical transmission. Other factors include avoiding breastfeeding during mastitis or in the case of both maternal or infant gastroenteritis. For maternal gastroenteritis, there's a reduced absorption of the ART, and for the infant, the gut inflammation may increase the rate of transmission. Once formula feeding is commenced, breastfeeding should not recommence.
Post-exposure prophylaxis for the neonate involves a variable regime of ART. The specific regimen depends on the risk of transmission from the mother. And lastly, the neonate should be reviewed by the neonatal or paediatric team and be tested for HIV RNA or HIV DNA PCR.
Why don't we just use a HIV antibody test?
Because of the transplacental passage of maternal antibodies. Maternal antibodies can be positive in the child's blood for up to 18 months. There are specific timeframes and duration of testing for the neonate, which is outlined in the ACID guidelines, but we won't bore you with them today.
Great. Well, let's summarise Sarah's management. For a woman with HIV in pregnancy, the antenatal management includes a multidisciplinary team including an infectious diseases specialist. Further testing including a HIV RNA viral load, HIV resistance testing, CD4, positive lymphocyte subsets, full blood count, UEC LFTs, a sexual health screening including syphilis, HCV, hepatitis B, chlamydia, and gonorrhea, and consider screening for HIV-related infections. Combined antiretroviral therapy, regular monitoring of HIV RNA viral load, CD4 count, and LFTs every 1 to 2 months, and delivery timing to be determined at 36 weeks with a viral load.
Intrapartum management includes in those with HIV on CART and a viral load of under 50, they can have a vaginal birth with routine intrapartum cares. In those with a viral load over 400, we should recommend a cesarean at 38 to 39 weeks. And in those with a viral load between 50 and 400, you should consider a cesarean section. In those women with term pre-labor rupture of membranes, then ideally delivery should occur within 24 hours unless the viral load is greater than 400, in which case you should do a cesarean section immediately. In those with PPROM at 34 weeks and over, the recommendations are exactly the same as term prom, But if it's PPROM under 34 weeks, then the decision's a bit more difficult and you should individualize it with a multidisciplinary team. And in these cases, it's super important to make sure that patient is on antiretroviral therapy in order to minimize the viral load.
And the indications for IV zidovudine include women with a viral load more than 1,000, untreated women presenting in labour or with SHRUM and an unknown viral load. You should consider IV zidovudine in those on ART with a viral load between 50 to 1,000.
Postpartum management involves the paediatric team at delivery, formula feeding, post-exposure prophylaxis, and testing the neonate for HIV RNA or HIV DNA PCR.
So that sums up this week's episode. So thanks for listening to the Uterine Sound podcast. If you have any episode requests, shoot us an email at theuterinesound@gmail.com. You can also find us on socials at The Uterine Sound, and don't forget to keep an eye out for our Instagram summary slides later in the week.